Right, so we are still waiting on a few people to trickle in, but whilst we do, I'm just going to offer a quick introduction to today's webinar. So hello everyone, and thank you for joining us. My name's Sarah Lesoye, and I'm a program administrator and research assistant on the Lustrum research program. For those of you who are unfamiliar with Lustrum entirely and are just here today to listen to all of the expertise from our amazing panelists, a quick introduction to Lustrum. So Lustrum is a 5-year research program funded by the National Institute for Health Research, NIHR, and is led by Professor Claudia Estcourt, who's one of our panelists here today. The Lustrum Study has aimed to improve the sexual health of heterosexual people and men who have sex with men, and the program has aimed to achieve this by preventing transmission of sexually transmitted infections and reducing undiagnosed HIV. So the program has been ongoing since April 2016 with a broad multidisciplinary team of co-investigators who've been hard at work delivering Lustrum's streams of activity. And today, the Lustrum team are here to share with you some of our insights into partner notification that we've gleaned from 5 years of extensive research and how partner notification might be able to offer some teachings and learnings to COVID-19, self-sampling and contact tracing. So without further ado, I'll introduce our brilliant guest speakers and then I'll pass over to them to get going. So first up, we have our chair, Professor Jackie Cassell, who is a medically trained academic and Deputy Dean of the Brighton and Sussex Medical School. She trained as a specialist in genitourinary medicine, sexually transmitted infections and HIV, and in public health medicine in London. And she's published widely in the field of sexually transmitted infections, focusing on primary care and the impact of delayed care on disease transmission. We're also joined by Professor Dame Anne Johnson, who is Professor of Infectious Disease Epidemiology at University College London, co-director of UCL Health of the Public, and newly elected President of the UK Academy of Medical Sciences. After training in medicine at Cambridge and Newcastle Universities, she specialised in epidemiology and public health, and her career has focused on research into epidemiology and prevention of HIV and sexually transmitted infections, as well as other infections such as influenza, Ebola, antimicrobial resistance, and COVID-19. Claudia Estcourt is Professor of Sexual Health and HIV at Glasgow Caledonian University, an honorary professor at UCL, and a consultant physician in sexual health and HIV at NHS Greater Glasgow and Clyde, UK, and Central and North West London NHS Trust. She is the principal investigator for the Lustrum Research Programme, and her research addresses 3 major NHS and public health priorities, so HIV, PrEP, public health programmes, clinical service development, evaluation and monitoring, self-managed digital care, focusing on the development and evaluation of complex online clinical care pathways within sexual health and HIV, and thirdly, preventing transmissions of STIs and reducing undiagnosed HIV by increasing the effectiveness of partner notification strategies. And finally, we're joined by Nicola, who is an infectious disease epidemiologist with research focuses on epidemiology, prevention, and the control of emerging infectious diseases and sexually transmitted infections. Nicola is co-chair of the Public Health Expert Group of the Swiss National COVID-19 Scientific Task Force. A major focus of her research in public health practice is contact tracing for STIs, HIV, and COVID-19. She's Professor of Epidemiology and Public Health, Director of Research, and leader of the Sexual and Reproductive Health Research Group at the Institute of Social and Preventative Medicine at the University of Bern in Switzerland. So without further ado, I've extensively introduced our brilliant speakers, and I'll now pass on to Professor Jackie Cassell, who's going to be our chair for today's webinar, to offer a quick introduction to partner notification and what you need to know to engage with the webinar.
Thanks, Sarah. Welcome, everybody. It's really delightful to have such a big and enthusiastic group of people. Some of us have been thinking about contact tracing for longer than it's been in the news. And interestingly, during the Lustrum programme, when we went and talked to people in the early days about contact tracing, a lot of them had never heard of it. We had to explain. But funnily enough, by last year, all that had changed. And we find that we're in a very different world where in some ways partner notification in STIs, if we've always thought about it, has been sort of left behind, whereas this new world's overtaken us. So what we wanted to do today is to explore with the expertise of the Lustrum team, with Professor Damian Johnson, and hopefully yourselves, because I hope this will be a very interactive session, what can the COVID-19 contact tracing and self-sampling response learn from sexual health partner notification, which is something we've all been doing for a very long time. So the conversations that we want to have later on, and I'll put this slide up again, is we're going to talk about, I'm going to introduce the landscape of contact tracing and partner notification, all that stuff about R and why we talk about it. And then we're going to talk more generally, and after the slides, about what do we do in STI partner notification and why? What are the challenges for us and how they're relevant to COVID-19? What could be learned from sexual health in the next phase of the COVID-19 response? And I think, you know, this is a really interesting time because we're just moving into the vaccination era where the purpose of testing and the kinds of responses we'll be making and who will be most affected are really at a cusp. Feels to me a bit like the cusp between having and not having antiretrovirals for HIV in the mid-90s. And what do the lessons from STI and COVID-19 responses tell us about outbreak control more broadly and for key vulnerable populations? And one of the things that has kind of very much come through in the COVID response, which you wouldn't have seen in other respiratory illnesses previously, is how socially structured COVID is. And one of the things we're used to thinking about in STIs is just how structured risk is by behaviours. And we're going to talk a little bit about that as a kind of setup for our later discussion. So I'm going to start, but not everybody has been thinking about contact tracing, partner notification all their lives. So a couple of quick definitions that are sort of fairly broadly accepted. So contact tracing for COVID-19, what do we mean by this? Well, we say the trigger to commence contact tracing is the detection of a probable or confirmed case, and that's often used, called an index case, particularly in sexual health, actually. And then what happens in contact tracing here is individuals who've been in contact with this case are identified and instructed to quarantine to avoid further transmission of the virus. And of course, what we might do may be changing soon. We'll be thinking much more about vaccinations as a next step. But that's how we've seen contact tracing to date. Partner notification in STIs, and this is conventionally described as a process that includes informing sexual partners of infected people of their exposure, administering presumptive treatment, and of course, in the case of HIV, soon after an exposure, that might be prophylactic treatment rather than curative treatment, and providing advice about the prevention of future infection. So I'm going to move on now. So none of us expected R to be so much in the headlines. You know, maybe I should leave it to Boris Johnson to give us a proper tutorial on how we manage R. But I thought I'd talk a bit about this, both in the context of STIs and of COVID. So R0 is called the case reproduction number, and that's how many cases a case produces, how many onward transmissions you get in a non-immune population, which of course is what we've been dealing with in COVID so far, and to some extent, but variably in STIs. And that is determined by the probability of transmission, the rate of partner acquisition, the rate of contacts, how many people do we bump into a day, sexually or in terms of COVID, in terms of close contact, and duration of infectiousness. Those are the determinants of R. So how do we use R0 in STI control? It's sometimes a bit of a moot point which category different interventions come into, but broadly there are some interventions we'd say are about reducing probability of transmission. That's condom use, microbicide use, Lowering viral load or bacterial load, such as HIV antiretroviral therapy, or in hepatitis C, that might also be an intervention. And of course, vaccination doesn't stop you having sex, but if you've been vaccinated against HPV, you're less likely to acquire it. And then the rate of new contacts. And here I'm just thinking a bit ahead about COVID. There's voluntary behaviour change, but also important, and we don't sort of think of it as something we can do, but structural interventions that reduce dependence on unwanted sexual contacts. For example, globally, education and employment opportunities for women have changed the structure and extent of sex markets. And then duration of infectivity. Well, for something like chlamydia, it will be treating it. For HIV, again, lowering bacterial load, that reduces the duration for which you're infectious. So it, is it probability of transmission? Is it duration? These things merge into each other. And then also asymptomatic and symptomatic case finding. So again, there's a range of things that we do to control R0 in COVID-19. Probability of transmission, mask wearing, social distancing. Social distancing, of course, merges with rate of new contacts liable to transmit, reducing visiting between households, working from home, closing schools, day centre support services, limiting informal and professional visitors to closed settings, such as obviously care homes, and isolation within households. And I put that in bold as I put the previous, as I bolded structural interventions, because of course, if you are living in a large and empty house, your opportunity for isolation at home is considerably less. And then duration of infectivity, symptomatic testing, asymptomatic testing. Vaccination, of course, will have an impact, exactly how that plays in, and potentially antivirals. So essentially, contact tracing in both those settings allows public health agencies to reach beyond the index case, the person diagnosed, and I know that will be a phrase you'll hear later, and act to reduce the parameters contributing to R in their contacts, plus or minus finding additional contacts. And that will depend a bit on what your opportunity is. Now, we sexual health people, we feel we've got a bit of a monopoly on contact tracing, and certainly there was a sense that the community had much more to offer than it had the opportunity to do last year. However, we're not the only contact tracing people. Obviously, there's sexual health contact tracers. There's also environmental health in every district or city council. We also have a large number of highly expert and very broad-ranging health protection practitioners in Public Health England and in Scotland in the analogous health protection organisations. Local authority teams have been increasingly involved in COVID surge testing, door-to-door testing, and so on, in a way that takes us back a long way when originally the sexual health clinics were set up by local authorities. And of course, there's now NHS Test and Trace, which is a complex organisation with links into various authorities, none of which are the ones that are conventionally embedded in local government. Now, you don't need to look at this in any detail, but the point I want to make here is that how long you're infectious for is quite a long time with sexually transmitted infections. 6 weeks to 6 months with gonorrhea, around a year for chlamydia, variable, but certainly 3 months to 6 months for most cases of syphilis, and variably onwards. And of course, these things are changing with vaccination, with antiretroviral treatments and so on. But the point I want to make is that STIs, you have them for long enough for us to do some contact tracing. And of course, in the case of HIV and the kind of and syphilis, which have long-term consequences, then it's worth going back a long way. So thinking a bit about the structure of risk, a very sort of well-worn way of thinking of it in STIs is you have a core group of people who, through their access to service and their behaviours, link to a kind of surrounding population, who then link further to a population who have very much less more diluted set patterns of sexual contact, and that's how transmission gets around. There are, of course, analogies with COVID, where we see huge disproportion. I mean, this is not a kind of real data slide, but it's sort of demonstrating the numbers of both voluntary and involuntary contacts that people have through different sort of home circumstances. So if you live in a not particularly well paid area, particularly well off area, you do a not particularly well paid job, you'll have more household contacts on average, you'll have more travel to work contacts, you'll have a lot more within work contacts, you have work break contacts, and we know that's an important place for transmission. Informal care is more than twice as common in the poorest communities, and that's 50 hours or more. So somewhere like Worthing, you're looking at 30%, 3% of people, 1.5% of people do 50 hours or more care per week. And you've got a huge disproportion where it's double that in a sort of typical coastal town around southeast of England or anywhere. Shopping, healthcare and other essentials, really we can all do that much the same, apart from in relation to caring responsibilities. So you're looking at huge disparities in the number of contacts, and therefore in the contact tracing opportunity, and also in terms of the consequences for those communities. So that's a bit of background. Be happy to answer any clarifications in the chat. Do feel free to use that. But what we want to move on to now, and I'm going to broaden the discussion and ask my colleagues to chip in, start with what do we do in STIs and why in terms of contact tracing. We can think about what are those challenges, how are they relevant to COVID, what could be learned from sexual health in the next phase of COVID-19, where we're going to be thinking much more about getting vaccination, getting support into communities, and then isolating an individual. And what are the broader lessons for infection control? It's always good to be thinking, you know, in this kind of very broad area. And of course, we work mainly in sexual health, but there are some of our colleagues in public health, and I hope some of you be in the audience and can chip in, who do a much wider range of contact tracing. So I think that's our last slide. Do follow us on Twitter, and indeed do share this on Twitter. And I'm going to stop there, and I'm going to hand over for first comments to Claudia, who is our principal investigator, and for her opening thoughts.
Jackie, thank you so much. And again, thank you from me for everyone who is listening. Jackie, as ever, has done a completely masterful distillation of all of the key things in a very few slides and drawn some fantastic questions out for us already. Just putting us in the sexual health lens, I'm sitting in clinic at the moment. So what we've been doing in clinic today, as has been happening in clinics across the UK, is that when we see somebody who we've just diagnosed with an infection, we talk to them about their patterns of sexual partner, their types of sexual partner in the relevant look back phase, which is usually between 3 and 6 months, to try and identify and then to help them work out how we tell those who may have been exposed to the infection, or may indeed be the index case, of how we can help them tell them about the infection and then get those partners tested and treated as appropriate. And I think just reflecting on the pressures that we've had within sexual health, nicely encapsulated by BASH President John McSorley on PM yesterday, was that we're talking about COVID now, but our pressures existed well pre-COVID. And I think there'd been a general move to focus on, heaven forbid, what we see as the important STIs. And because of resource restrictions, and because partner notification requires skill and time and patience and follow-up, I think we had actually largely been forced to neglect some of the work we were doing for infections like chlamydia, and to focus on gonorrhea and syphilis. To my mind, they're all important for different reasons. So in terms of an overview, and just really to finish, to get everyone on the same page as to what normally happens, the range of options would be, if somebody has an STI, they will be asked if they would like help notifying their contacts. Some people say yes to some contacts and no for others. And then there are a variety of ways that we can assist rehearsing conversations, breaking the news, talking about getting partners in for care, and perhaps even notifying partners through an anonymised service from the clinic, either by phone call or by text or by other digital means. Jackie, that was a quick roundup. I'm going to finish there, otherwise this will be a monologue.
That's okay. Yes, that's a good idea. So I just wonder if it would be really helpful if maybe Nicola, you might like to give us a reflecting on the analogies and the disanalogies between. I deliberately didn't give estimates for periods of infectivity, but clearly one of the really striking differences is how long you're infectious for and the things that we have up our sleeves. So are you able to comment there?
I'll try and marshal some of my thoughts because having trained in STIs for the past year and a bit, I seem to have forgotten everything I ever knew about STIs and been immersed in COVID and SARS-CoV-2. But what it does give is every time someone mentions something about contact tracing for COVID, it sparks off another neuron that says, yes, we've been there. And it does seem in some way that COVID and the COVID control groups seem to think that they have invented contact tracing. And one thing that is interesting from my point of view is that I trained in the UK. I did all my STI contact tracing training in the UK. I've been living in Switzerland for 20 years. And in a way, COVID people did invent contact tracing because contact tracing has nowhere near the same kind of awareness in the population and really isn't done. So maybe we can come back to that. I wanted to sort of pick up on a couple of things and a couple of these analogies. So the core groups thing was one that Jackie said, and there your core groups are actually people in the public eye, because they're the people who have to go to work. So the opposite happens with STIs, is the people, sex is a private activity, and the people with, you don't know how many contacts people have with generally, unless you ask them in very, very sensitive ways. If you say, I work in Migros, which is one of the supermarkets, everyone knows where that is and knows that you've been in contact with lots of people. Whereas had you contracted an STI, you would really have to elicit this information very carefully. So that's one difference. Another difference, it comes up about who does contact tracing, and this is a sort of historical trip through contact tracing. So it is natural, if you have COVID, that someone will get in touch with you and ring you up and say, you have been in contact with someone who has COVID and we need to find out whether you're at risk of going to quarantine, blah, blah, blah. That is an incredibly rare event now for if you have an STI, where what we're now used to is you are told, if you're the person who has the STI, you're told that you have the STI, and you are told that it's your job to go and tell the people that you've had sex with that they need to put themselves in touch with some services. This is all patient-led. And at the height of the COVID waves, when the contact tracing system collapsed, in common parlance in Switzerland, it probably did in the UK as well, there were people in Switzerland who were being told that they should tell the people that they had been in contact with that they should go into isolation. And this, for a country that's not used to having contact tracing done, there's absolute uproar. Like, how could this possibly work? You're telling me, where's the professional who's coming to give me the information? And this is actually, I think, really quite a nice stark contrast, because of course, provider-led partner notification for sexually transmitted infections, while still done for people who have particularly complicated histories or really don't want to get in touch with their partners, is kind of a thing of the past. So that's maybe somewhere that contact tracing is going. One thing that both of them do have in common is that contact tracing works very much better when there is not very much infection around. And I do find it this kind of paradox, because in the COVID response, everyone has put at the heart of it the test, trace, isolate, quarantine package of infection control measures. And they call it out and say, this is what we depend on to break those chains of transmission. And the paradox is that when you have lots of transmission going on, it simply doesn't work, because the times between getting tested to getting results, getting into quarantine and isolation are too short. And there are too few professionals to do the contact tracing, and it's doubt. And at that point, when you have that situation with COVID, with a respiratory disease, what you would rather do is to have some measures that mean that larger numbers of people have to stay home. So you have stay-at-home orders, you close businesses, you close non-essential businesses so that people just aren't coming into touch with each other. And I don't really see that happening with any kind of STIs. I think I'll leave it there, because I also don't want to. I could, as you know, go on for hours, but I will leave the floor open. But maybe it has stimulated some ideas about other analogies. Oh, just lastly, the thing about the infectious period, of course, you know, if you have a lot of contact tracing, well, a lot of contact tracing for COVID happens after the person has stopped becoming infectious, and we don't really know how. In fact, that probably happens for STIs as well. It's not a difference. And it comes down to the diagnostic testing, which done by PCR, which picks up minute amounts of nucleic acids, which we're perfectly happy with an STI to say, oh, this is an infectious person because they've got a positive PCR. And very soon in COVID and SARS-CoV, people are jumping up and down saying, those people with PCR positive tests, most of them are non-infectious. This is a really, really important thing that COVID is going to bring back into the STI field. And I think that it goes beyond contact tracing, but it's actually about STI management and what we think of as an infectious person. So I will shut up now.
Thank you, Nicola. That's really interesting, and I was very struck by your point, which I've come across in other worlds, that that people think contact tracing is completely new, and that's a kind of, and maybe it's one of these things that always has to be invented. And I do recall your Euro surveillance report, which showed just how very different cultures and practices around contact tracing for STIs were across Europe. And I wonder if I could ask you to come in and comment on, you know, where you see these issues, and also where you think things might be going next, because we're at quite an interesting tipping point, aren't we?
So Jackie, thanks very much. I mean, it's a fascinating discussion, and I think it's worth going back to first base. My own view about COVID is that people have, throughout actually the entire test and trace program, have overinflated what could be expected from test and from contact tracing per se in terms of reducing R, which is what one's trying to achieve with COVID. I think you could argue that you're trying to achieve something different in STIs, beyond reducing R. So the first point I would make is, in COVID, the only intervention you have in your pause is to say, well, you must do something altruistic, which is to stay home and stay out of everybody else's way, in order that you stay home before you become, you will have already been infected, if you like, or not, as the case may be. And you must now isolate for a period and see whether or not you become ill. And then you must stay away from people to break the chain of transmission. So the only benefit to you is the altruistic one of not passing it on to somebody else. But you may suffer serious disbenefit because you can't go to work. And indeed, you know, for all the reasons that your social life will be altered, for example, we're all in that situation now, but you know, where you've got low prevalence, you're actually asking people to restrict their activities. Conversely, for most STIs, I would, in fact, possibly for nearly all of them now, there is an intervention which can treat you for your STI or reduce your risk of acquiring it, and and you have an intervention. So I think that's a fundamental difference in what the benefit is to the contacted person. On the issue of the time frame, clearly somebody with HIV may be infectious for months, weeks, years even. And so there are, there are a whole bunch of prevention issues which are very different from the ones that which we rely on for something like COVID, where you've got a very short duration of infection. So critically, you may miss cases of through contact tracing for STIs, but the urgency is much less. And I was involved in a piece of work published by the Royal Society Delve, which pointed out that really, unless you can get unless you can reach contacts within 3 days of their exposure, in other words, before they become, because there's an incubation period between exposure and becoming infectious, which we know is a median of 5 days, then you've got to get people. You've not only got to diagnose the index case, but you've got to reach the contacts before they become infectious. So speed is of the essence. And in this paper, which we did through our society, we pointed out that all contact tracing systems, and it's true for STIs, are highly leaky systems. Now for COVID, and true for STIs, because they're very often, you can be infectious but asymptomatic, so you're unknowingly infected, so you're never going to identify all the people that are infected. In COVID, they will stop being infectious within a matter of days, but maybe a matter of months for STIs. So contact tracing, in a sense, may have because you can do it more, not leisurely, but you've got more time, you continue to have a benefit, whereas the benefit from contact tracing is over a very short period in COVID. So you need to, for COVID, it needs to be very fast, it needs to be very complete, and you're very dependent on compliance of people with the advice you give them to self-isolate. And we know from all the behavioural studies that have been done that not only is self-isolation compliance with it limited for those who are infected, it's also limited for those who are contacts. So when we did these estimates, even assuming very high rates of compliance, very high rates of detection of infection, and very high rates of contact tracing, the estimates, when you look through all the leaks in the system all the way down the road, contact tracing per se brings you very little added benefit in terms of reduction of R, which is something which actually Sage commented on in a recent paper. I don't think people have actually really thought about the absolute reduction in R which a good contact tracing system might achieve for STIs. I mean, the other problem, it's a common one with STIs as well, is that with STIs, it's much easier to get hold of the regular partners, much more difficult to get hold of casual partners or anonymous partners. Very similarly, in COVID, if you look at I was just looking at the test and trace data before we went online. For COVID, the vast number of contacts that people are actually in the test and trace program are actually household members, but they are automatically expected to isolate anyway. So one really has to look at the cost benefits, and this is true for contact tracing for STIs. We really ought to be doing much more economic analysis, because the investment in test and trace has been enormous, and the testing per se, yes, I think hugely useful for all sorts of reasons, but actually the actual contact tracing bit is not the bit that brings you the benefit. The benefit actually, in terms of reducing transmission, is that people self-isolate in the first place before they become tested, not after they come tested. And the advantage of testing is that the negatives can go back in society for COVID and get on with their lives. The positives, on the other hand, have to stay home. For my money, I'd like to see a lot more money put into trying to reduce transmission within households, which is a very high fraction of all infections. We don't understand that very well, how to reduce it. And on the point made that as your R falls below 1, and you hope, as we are doing now, that you're pushing the virus to lower and lower prevalence, you need to be looking, just like you do for syphilis and gonorrhea, you start looking in the core groups for identifying cases, i.e. those who've got the highest rates of partner change. For COVID, you need to be looking at high transmission environments, which are frequently actually healthcare environments, again, not given enough attention for prevention. I could talk a long time about that, but I won't, Jackie, because you're giving me the please stop now, look, and social care environments. So I think there are a lot of, we need to think about this much more in the round, and I think there are learnings in both directions.
I think, I mean, I wasn't trying to stop you, but I was going to make a point which Claudia has shared in the chat, is that, I mean, not only is partner notification always a complex intervention, but I'd like to press Nicola and Anne a bit, particularly on what is the intervention going to be as what we have available changes. So, for example, you get a case of hepatitis A in the nursery, you might do some ring vaccination, and increasingly the people who get COVID are going to be the people who do badly paid jobs and they're out there and may well live in communities for whom there has been more reluctance. So what's the intervention going to be as we move into the vaccination era, and what does that mean in terms of what we should be thinking about? Because STIs have always been stigmatized and in dark and quiet places. What can we learn from that? I think it would be a question I'd want to put to all of you.
So I go back, Jackie, to going back to the very beginning of HIV, when testing at all for HIV, and I'm going back to the 80s now, was completely stigmatized. And what we've learned over time, well, I mean, I think I would give a lot of credit to the gay community for, improving exchange of information and building community support. So for these, the fear now is COVID remains in excluded communities, or communities with low vaccine uptake, or with whom there's poor communication because of language and so on, and so that kind of community intervention to not only reduce transmission, but also to ensure high rates of vaccination and building trust in communities, because the evidence of why communities don't take up vaccines, a lot of it seems to be based around issues of trust. So there's a huge amount to be done around local interventions and working with communities, I think, when you're getting to the level of outbreak investigation.
And I mean, this point about some of the rather brave decisions made early in the HIV epidemic that, we weren't going to require testing, for example. Claudia, Nicola, do you want to comment on that, as we move into the next era of, what is it that sexual health clinics have to offer in terms of having worked in those ways with often those, very similar populations?
Well, it's
Nicola, do you want to go first, or shall I go?
Just very briefly, it is another sort of reinvention of the wheel. And just as Anne said that about HIV and testing in the 1980s, in the 1990s, when people suddenly realized that there are minority ethnic groups that are at much, much higher risk of gonorrhea, and how difficult it was to say that. I remember that it was impossible. We had to say that we worked at King's and we worked in Lambeth, Southwark and Lewisham, but to say which places, which wards in these boroughs were particularly affected was not possible, because of the stigma of a community, of blaming a community. And I very much see that has happened with COVID again, and the tendency is to blame the community for their vulnerability, which is and so there is somewhere that we haven't learned from again. But if we come to the role of contact tracing there, and about building trust, when rates of infection are low, it gives a bigger role for contact tracing. So in fact, you do have, whilst I completely agree with Anne that the actual contact tracing itself achieves very little, but what it does achieve is finding out where there are populations of risk, finding out what those risks are, and being able to put in place interventions that reduce the risk. And for COVID, we have backward contact tracing. So I mean, this is another bizarre thing. Source contact tracing, a complete revelation that you would actually look for the person who gave the infection to you rather than the one that you gave it to. Of course, to us in the STI field, you always want to look for the source. But for COVID, for a respiratory infection, I think that this kind of contact tracing, where you go back to the source and you see where these high risk environments are, that really is a role for kind of public health interventions. And what it has taught us about making safe places to work is phenomenal. Yeah. And I think that is something that we will take forwards with us, and that we should promote.
I think that's so important. You're looking at settings and not just at individuals, and that's a big shift.
Yeah.
Will be continued.
Jackie, I would absolutely endorse that. So I mean, it's easy to overstate the contribution of contact tracing per se, may be relatively limited, but I think the point about in that outbreak situation, it's very different. And if you think about something like MRSA, where we had an attitude towards MRSA that any case that occurred in hospital of transmission should be subjected to root cause analysis, and you try to understand the circumstances in which that transmission took place. And we really need to think about, and then try to put in the systemic, behavioural, but also practices which reduce transmission. And we need to think about that in hospitals and care homes. How do we organise staff better? How do we reduce transmission in all environments in hospitals, not just in clinical spaces, but non-clinical spaces, very important. How do we educate staff? How do we ensure high levels of vaccine uptake? All those issues are incredibly relevant. And actually, you need an approach which is based on that understanding contact patterns through contact tracing, but also advising people in a timely way to prevent transmission. So environments alongside systems for contact tracing seem to me to be extraordinarily important, so that you make the systemic alterations to reduce spread.
So I'm going to ask Claudia to respond there, and then I'm going to turn to some questions from the audience. So I've got some already, but please do add in questions in the Q&A, or if you prefer in the chat, and we will get to as many as we possibly can. Claudia.
So I'd like to build on Anne's. I agree it's environments, I agree it's systems, but it's also people. And I don't think there's been many people who have walked a mile in other people's shoes during COVID. And this is absolutely critical. It is solid science. We're talking about development of complex interventions for which there are barriers and facilitators, and my barriers may be different from somebody else's barriers, and my facilitators will be different. And so the solutions need to be deeply rooted in this cultural sensitivity, and the solutions may need to be different, and the support will need to be different. And we are used to that within sexual health settings. That's something that is just bread and butter for us, is trying very hard to understand the individual. And I totally take on board the magnitude of the numbers of size of infections is very different. And we have specialist health advisors who are really good at that. We think about behavior change. And I think just pulling all of this together, it does fit nicely through that lens of complex interventions, highly complex, many different actors, many different agents, people needing to change their behavior, do things that they don't want to do, be told to do things that they don't want to do, some of it for altruistic reasons, and some of which we didn't really mention reinfection and preventing that if you're the index case with STIs. So I think, yes, environment, yes, systems, but we can't forget the people, and we have to embrace that diversity, understand those individual differences, those differences experienced by different groups because of where they are, because of their jobs, because of living, and think about it through that lens and how to reduce those barriers to really help people engage. And it's communication. And I know we have together had lots of discussions about how poor communication of rationale has really hindered people's understanding. So I'd add that to my little package of intervention components.
Thank you. Now I'm going to turn to some questions we've got in the Q&A, and a really lovely comment from Tarzy Small of Nottingham saying that how they took on, the Sexual Health Service took on responsibility for COVID testing for the Trust, and that's been a real success by the sound of it, and the Sexual Health Services are opening up fully from June. So that's really good to hear that recognition. And Pam Sonnenberg asks, Are there lessons from TB contact tracing in respiratory and household transmissions and vulnerable populations? And we've also got a further question about, which I think is related, stigma in contact tracing. So I wonder if any of you like to comment on those?
Well, I thought it might be worth asking Pam Sonnenberg, who's the TB expert, to give her opinion. Is she allowed to talk?
Brilliant, yes. She's allowed to speak. Yeah, brilliant.
Hi, I think that's a first to be thrown back your own question. I hadn't thought about it as much till this webinar, to be honest, and I think that's really interesting that this is a webinar that's really helping us to think across infections and across what we've been doing, not only for decades, probably for many decades. And TB has always had contact tracing. When you've got a person with TB in a household, it's the mainstay of what's done locally. And I think that my main message would be is that local services know their populations, and maybe that's the message that TB contact tracing above everything can show, that you can't give put an app out and assume that people in vulnerable populations are going to be using it, whereas as local communities and local services are the way. So that would be my main response to that. But my second one would be thinking about the transmission of the particular infections and how homogeneous they are within populations, as opposed to STIs, which are more focused, as you mentioned, Jackie, within specific groups. And so just thinking of the transmission dynamics of different pathogens. But thanks for throwing it this way, but now I'm throwing it back to you.
It's interesting. I mean, there are sort of, I always remember Nicola's European work, but one thing that really struck me in the UK, I did a survey with Sophie Herbert, who's a GU doctor now, of what sexual health services would do if they got a measles case or a hepatitis A case. And and actually I think this helped us change a bit, but basically they would not do the same as what would happen if it was a GP or whatever. So there is something about sort of cultures, both learning where you're not doing it quite the right way, but also cultures about thinking it is possible to do things differently. And I think one of the things, with sort of self-isolation for COVID and so on, we're going to have to think how we move into a more supportive mode, because that has been a terribly damaging element, I think, of the response, really. Have we any more questions? Isabel, you said that that Claudia had answered your question about stigma, but I just wanted to, would you like to say where you're coming from in that? Isabel Carrick, do feel free to put on your mic. Hi, Isabel.
Hello. Sorry, I was just trying to work out how to do that. Yes, I think it was just thinking in terms of COVID, because we were talking about stigma in different communities. But I think certainly in terms of people, if you're in a low income employment, and actually testing would mean that you have to isolate, and also that your colleagues would have to isolate, and those sort of wider impacts on people's lives are maybe as much of a barrier as stigma. And I was just thinking, linking that back to sexual health, that we can focus on the stigma element, but it's that thing about what restrictions people will then face if they come forward and then get given advice as to what they have to do. That was the sort of idea that I had. And Claudia was just talking about it.
Yeah. Would you like to comment?
Yeah, I think we have it easy in a sense in sexual health, because one of our enticements or inducements for contacts is really about, well, you might have got an infection that you don't know about, and of course we can test you for it, and if you have got it, we'll get you tested, we'll get you treated. Oh, and by the way, we've got lots of other vaccinations and great health promotion interventions. We've got PrEP that we can give you as well if it's appropriate. So I think this makes things quite difficult with COVID, because it's always going to be a downer. So, I suspect many people on this call have received the phone call that you were a contact after self-isolate. There's no upside, absolutely no upside. Whereas within our world now, there are many reasons to be optimistic. even when you're breaking the news to somebody that they may have been exposed to an STI. Now, I know I am the world's best optimist and I like to see the sunny side of life, but I think this is quite a big difference. And certainly it is one of the tactics that we use to reduce stigma, looking on the positive. There isn't that much positive to do with COVID. And I think that does make it more difficult when you're notified as a contact.
I think, and can I add something on that? I mean, I've been doing a certain amount of work on domiciliary care and care homes. And one of the things that's really striking, I mean, not only is it very unclear what is a household, but there are stigmatized kinds of households. And so that, you know, the kind of thing about moving children between households, perhaps you're doing some sort of slightly unpaid care responsibilities. And one of the things I remember from my days in health protection is that, you know, doing contact tracing for a meningitis case. And where were those 15-year-olds sleeping on that Friday evening? They're all at their best friend's house, but so how do you do, you know, there is something about supporting people who are in the most difficult and badly paid, complex, busy households, not only to physically self-isolate, but to kind of feel that this is okay. And I think that that's a kind of really an element of stigma that I think we need to perhaps think a bit more about in the context of COVID.
Now, I would perhaps add on all, I mean, these are incredibly important issues, is that one of the concerns has been about social support for people, so that, you know, notably financial support for people not working, but also how do you protect in complicated multi-generational households, for example, where there are high levels of informal care or informal caring, but, you know, between households, which result in multi-generational mixing. And there has been, and I think there remains, a sort of sense that technological solutions, which are a kind of sine qua non for a lot of this, that you've got, you know, we now have the opportunities of apps and, you know, tests and remote tests and so on, which all of which performance characteristics we have to understand. There's only actually the systems that you put into them which will achieve the public health output. And there's very little formal evaluation of that, particularly cost economic analysis. So, you know, the cost of test and trace compared with what gets put into contact tracing for STIs is just, you know, orders of magnitude higher, and, you know, many times higher than the budget of the whole of PHE. But if you were to try and figure out, okay, this has all been done in a crisis, but I really do think we have to think a lot more about trying formally and honestly to assess which bits of the system have resulted in a public health benefit, by which I mean the effective reduction of transmission. And if you had that much money to spend again for the same public health benefit, or even a greater public health benefit, could you have spent that money in a different way, for example, through mechanisms of social support and income support and all those kind of things? And in the rush to sort of get things up and running, a lot of the decisions have been driven more by the technology and the kit and the numbers than it has been by outcomes. So that would be my message going forward.
We've just had a fantastic question, which I've put in the chat to the panelists, which is, and you're going to have 30 seconds on this, I think. This is a good closing set of questions. I know you won't do quite 30 seconds. Could the panelists each share their main recommendations for moving forward with COVID management in preparation for the winter season in the UK context? Was that a setup, Melvina? It's a very good question. So I'm going to ask Nicola, would you be prepared to go first, perhaps with an international comparison?
I think that what I will be doing is telling people not to become complacent and assuming that because we have vaccination, everything will be all right. Firstly, it may not be all right in the UK. We're talking about variants of concern and those that escape vaccine control. My main recommendation actually is one of the mantras from WHO, from Mike Ryan, is that we are not safe until everyone is safe. And actually my concern is for populations in resource poor settings where they really, really need to be able to get access to vaccine, because we think that they are avoiding and somehow not getting affected, and they will do.
Thank you, Nicola. Claudia, to you next, as somebody absolutely embedded in the sexual health world?
So we have to evaluate what all of this money is being spent on and really make some sort of assessment of the impact. We've already said that we feel it has probably had very little impact. I think that needs to be expressed, and I think that needs to be better understood. Hopefully why it worked when it worked and why it didn't work when it didn't work. Secondly, I think we need to start now co-producing interventions that will help so that we are ready for the future. There's a wealth of knowledge and we're not using it at the moment. And finally, whatever those interventions look like, it goes back to what Anne is saying, absolutely critical. Some of us, I have to say, were saying this from the start, that the S is in there for support. Life is not equitable, COVID is not equitable, and the impact of isolation needs to be really appreciated, that the support in there is fundamental. Otherwise it's really all pretty pointless, other than for those of us who live in large roomy houses who have nice jobs that pay us when we can stay at home and we can get Ocado to deliver.
Yeah, thank you. And Anne, you predicted last winter, next winter.
Yeah, well, I have to say we're doing winter 2.0 for the Academy. We're doing another report. So, and you know, a lot of the things are the same. Work off the backlog, support the NHS and social care staff, vaccinate the world, optimise vaccination uptake in this country, particularly working with vulnerable, disadvantaged groups, vaccinate against flu, because I think if we're open next year, there'll be huge uncertainty about emerging infections. Also test for flu and COVID, so we can distinguish, because for flu you have got antivirals. And I'm afraid my mantra will remain, build resilience to reduce transmission in hospital and care environments, because I think that's been a very important, that rotating door, the interaction between high risk environments and low risk environments. You saw it for STIs, it's also true for COVID. So build resilience in health and social care to reduce transmission, increase winter support to vulnerable communities. And a last one, I can't read my writing as I had the advantage of going last. Intervene early, look for any upticks and intervene early and fast, and make sure we educate the public, all of the public and all of the publics, working with closely with local communities across the piece.
Thank you. That is fantastic summing up. Sarah, please put your camera on again, because I would like to thank you very much for putting all this together. And I'd like to thank again Professor Nicola Lowe, Professor Claudia Estcourt and Professor Dame Anne Johnson for a really fantastic discussion. And thank you to all of you for putting your questions in and being prepared to be picked on. Thank you so much.
And thank you, Jackie, as well, for a fantastic chairing job. We can always talk for about 5 hours, so you did marvellously. And thank you, Sarah and Nicola and Anne.
Thank you.
Thanks so much, everyone. Just a final word to say, if you were interested in attending our next webinar, which is going to focus on Lustrum's trial methodology and look at the approach to cluster RCTs that was used in the APT trial, which was Lustrum's main piece of work, that's going to take place next Tuesday, the 18th of May at 4 p.m. And you can register via the same link that you used to register for this. So if that's of interest, we hope to see you there. But thank you again to Jackie for brilliant chairing and for all of the panelists for your amazing contributions.